Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Dr. Jamila Ben Adi, and it gives me the pleasure to be your moderator for tonight's session, arranged by the Emirates Society of Internal Medicine about the updates in diabetes and obesity. We have two distinguished speakers here who will be leading the webinar today. We will have two topics. The first topic will be about the prevalence of obesity in diabetics and will be presented by Dr. Mohammed Hassanin, who is a consultant endocrinologist in Dubai Hospital and the professor of medicine in Gulf Medical University, UAE, and deputy director of postgraduate diabetes education in Cardiff University, UK, and chair of the Diabetes and Ramadan. So welcome, Dr. Hassanin.
Assalamu alaikum. Ana Dr. Jamil. Okay, so let me share my screen. So thank you very much, Dr. Jamil. Assalamu alaikum, everyone. It's lovely to be with all of you after the long summer break and starting alongside my very good friend and colleague, Dr. Salah Abu Snana, and hosted by the Internal Medicine Society, a society that we all belong to because in our training we were also part of the internal medicine subspecialty. I'm one of those people who are dual certified. And the topic of tonight is about obesity and diabetes. I'm gonna touch on the link between the two and hopefully, inshallah, we will be able to, between myself and Dr. Salah, to give you a comprehensive coverage of the topic. So we all know that obesity is becoming an epidemic. This is data from the United States of America. I think you're all familiar with the fact that as time passed by, red is 19s in the early 60s, and orange is 2006. So that's 15 years ago. And in this short time scale, the prevalence of obesity in the USA has tripled in men and over doubled in women. So it's really an epidemic. In our region, here I share with you the photos of three important cities in the Middle East and Asia: Alexandria in Egypt, Dubai, and Delhi. And as you can see, 60 years ago, these cities looked calm, nice, less populated, perhaps not as developed as it is now. But the impact of what we see nowadays in our cities is a true sign of westernization and urbanization. When I look into the MENA region and specifically into the Gulf region, the change in wealth over the last 50 years have led to a rapid increase in intake of refined carbohydrates. This has led to biochemical factors affecting the glucose tolerance, the blood pressure, and the lipids profile. All this with the impact of urbanization and the very sedentary lifestyle have led to type 2 diabetes. In the center of all this is obesity. Obesity is kind of the center that all of these factors lead to and end up out of as well. So really, it's quite important to understand the link between obesity and diabetes. When you look into the NHANES data, which is very important data from the USA, looking into diabetes, hypertension, or dyslipidemia, according to the body mass index. And let me tell you about the color code. White is those who are underweight. Dark blue is those with a normal weight, or maybe white is those who are lean. But as you can see, what we see is very little white, a bit of blue, but the vast majority is all the other colors, which is overweight, as well as the different levels of obesity. When I look into the data of Dubai Households Health Survey, which was conducted, the last one conducted in 2019, I had the pleasure to be one of the survey team among many colleagues, including my dear colleague and friend, Dr. Fathi Al-Awadi, and many of the colleagues from the headquarters of DHA. You would see that within Emiratis, normal weight was 27.9. For expatriates, it's 36.5. So the total across the whole of Dubai as an emirate of normal weight is about a third of the population. 2/3 of the population are either overweight or obese with different proportion depending on whether you're national or non-national. So clearly in nationals, there is more obese than overweight, and the opposite pattern is for the expats. But it's not just about being overweight or fat, it is where the fat is centralized. So is it the apple shape or the pear shape? And does this matter or not? Well, the apple shape, when the fat cells are centralized in the abdomen, the intra-abdominal fat, this leads to large insulin-resistant adipocytes. This causes an increase in adrenergic receptors and obviously cause increased insulin-mediated anti-lipolysis, as well as an increase in catecholamine-mediated lipolysis. This is leading to increased fatty acids. And that's not the case when the fat cells are centralized as a pear shape, not in the center of the abdomen, but around the hips and the bottoms. So here you have the small insulin-sensitive adipocytes, and the adrenergic receptors are not stimulated, they are inhibited. So this is really very big difference between one and the other. When we look deeper into the household survey, and we try to look into who has got central obesity based on two parameters, the waist circumference and the waist-hip ratio. And here is the data of the waist circumference. So you end up seeing the pattern in the country or in the Emirates that females have far much more central obesity based on waist circumference measurement. And central obesity in data from Abu Dhabi as well has been very much prevalent among men and women across the data of Wuqaya, which is 50,000 national persons who were screened for all the cardiovascular risk factors. So you can clearly see whether it's men and women, it's gradually increasing with age. But the worry is when you look into the data of those who are pretty young, between 18 to 20, and indeed 20 to 29, we are really talking about 35 to 40% have increased central obesity. So this is greatly worrying. But when you measure it based on waist-hip ratio, we can see that men have a much, much higher waist-hip ratio compared to women, because perhaps men do not have the pear shape as much. So you end up with such a difference. Nevertheless, the data are showing that there is increased obesity regardless of the pattern. Now, when you look into this similar data from Pakistan, which was recently published regarding the prevalence of diabetes and obesity, you would see that the vast majority of people with diabetes are either overweight or obese based on the different pattern. So body mass index, the higher it is, the higher the prevalence of diabetes. Waist-hip ratio, the higher it is, the higher the prevalence of diabetes. And indeed, with waist circumference, the same is the case. It's not just about Dubai or Abu Dhabi or Pakistan. In fact, it's across the whole of the region. If you look into prevalence of obesity in Gulf countries, in Bahrain, in Kuwait, the best data are there in Oman. The data here from the World Obesity Federation is perhaps a touch old and is slightly underestimating the current prevalence in UAE. So the bottom line is we have plenty of people with obesity. It's not about an image. Obesity is not that you look into the mirror and you say, I don't look well, I don't look nice. Obesity is about the risk for health, and the risk for health is multiple. The diabetes, the hypertension, the cardiovascular impact of this, the dyslipidemia, the gallbladder and the fatty infiltration of the disease of the liver, the cancer, which is increased in obese people, and of course, the impact on joints with osteoarthritis, and indeed the sleep apnea, which can impact on the heart as well, that comes with people with obesity. So specifically looking into the link between obesity and diabetes, well, it's important to remember that the fat cells in the intra-abdominal fat cells are not simple inert fat cells. These, in people who are genetically predisposed, who are exposed to increased caloric intake and sedentary lifestyle, swell. And that leads to increased release of free fatty acids and increase of the release of the inflammatory factors and adipokines, and indeed other adipose tissue dysfunction, leading to the hypertension, the dyslipidemia, the abnormalities in the liver level and the muscles and the pancreas, and all of this is an atherosclerotic marker, which can lead to indeed many cardiovascular problems. When I look into our data from Dubai Hospital where I work, and I look into how many of our diabetic persons from a sample that we collected last year, over 2,264 persons with diabetes. Those with a BMI of less than 25, equal or less than 25, are 14%. Another 32% are overweight, up to BMI of 30. But the others are indeed obese with different levels of obesity. So clearly, people with type 2 diabetes attending our clinics have different level of weight problems that need to be addressed. Now, the question really is, why has obesity increased specifically regionally rather than just globally? So we all know that it is related to the type of food and the quantity of food and the sedentary lifestyle. And these three factors are in abundance in our beloved country and region here. The food that is rich in carbohydrate, as you can see from the picture, the quantity of food and the generosity of the portions, and indeed the sedentary lifestyle where you don't even have to walk from the car park. The vast majority of places have a valet parking, which is even provided free. So you don't have to do any physical activity. Thinking of the food portions, when I look into food in my hospital canteen, and this is a photo from my hospital canteen, you can see the generous portion of rice and the lack of vegetables or salads in specific need. If this plate would have half the amount of rice, it still would be a generous portion. Indeed, when I took this photo on the left-hand side in Turkey, in Istanbul, when you see the size of the baklava and the kunafa, and you see the portion size, you also realize that not only our food is rich in carbs and fat, but the portions are indeed very big. When I look into data from our health survey of 2 years ago and asking people whether they have been eating the recommended sufficient fruits and vegetables on a regular basis, it's only less, it is roughly about a third of the population. Whether they are national or non-national, they are all 36% give and take. So clearly, it is not just about the type of food, or the portion of food, but indeed the selection of the type of food. Moving on to physical activity, or rather physical inactivity. Many people get a dog to walk the dog, but this photo is a nice example of how much some people perhaps would go a long way to not exercise. Having the regular aerobic exercise and having the regular anaerobic exercise is really very important, but unfortunately, this is hardly practiced in our region. The data from 2014 health survey, which we published a couple of years ago, showing us that those who spend 10 minutes doing different types of physical activity as part of work, as well as housework, on a daily basis is only 17%. And those who are doing it 1 to 3 days a week is 18%. So only 2/3 are doing 10 minutes, only 10 minutes of 4 to 6 days per week. And when you look into a bit more intensive physical activity, such as running or playing football for 10 minutes continuously, this is not practiced by 95% of the population in the Dubai Health Survey of 2014. So clearly there is a big issue. When we asked the same question in the survey of 2019, the amount of person who is doing sufficient physical activity, that's in total in Dubai of 20%, slightly higher in national compared to non-national. So clearly, not only we're eating the wrong type of food, we are also hardly doing enough physical activity. And that's not just here. When you look into the data from across the Middle East, you will find that it is indeed the vast majority of our countries have over 50% or even 2/3 of the population with low physical activity. I looked into this in one of the studies that we did across a number of countries in the MENA region, and inactive was mentioned that it is 22%, low activity 41.7%, moderate activity 31%, high activity by only 4% of people with type 2 diabetes. In this survey, we looked into a large proportion of the population. As you can see here, the data is quite large. 1,700 persons in total were surveyed, and this is their responses. So how does this impact on diabetes? Well, we know that the prevalence of diabetes based on the survey shows that in those who are obese, it is much higher than those who have normal weight. But I would like you to look here into the arrows, the green and the red. This is the prevalence of diabetes in those who are exercising, and this is those who are not exercising. We are talking over 2.5 times the risk by simple exercise. And when we look into the similar data from 2019, it is double. So in the Emiratis, those who are physically active, the prevalence of diabetes is only 10%, regardless of their weight. But those who are inactive, it is double, it is 20.2%. And the same applies for the non-Emiratis as well. So when you look into expats, it is 10% versus 25.8%. The problem is even worse in the expats if they are not active enough. It is 2.5 times. So clearly, physical activity is even more important than the actual weight parameters. Now, this is a Google map of my beloved country or city, Alexandria. This is one of the old clubs, sporting club, and this is the other sporting club in Alexandria called Smuha Club. Sporting club was established in 1890. So that's 130 years or 31 years ago. Smuha Club was established in 1949. Now, you would imagine that when the population of Alexandria between 1890 to 56 years later, they developed another big sporting club. But unfortunately, over the last 70 years, there's been no other sporting clubs in Alexandria. Now, these clubs are huge membership clubs. It's not like it's a professional football club. No, it is clubs that members of the community would have a membership, and will go with their families to play and to also socialize. So I would love to see that in Dubai and in the various Emirates. But unfortunately, as things have not developed very much in Alexandria, when we did a survey, a study there a couple of years ago, it was published in 2018, the prevalence is as high as the Gulf. Total prevalence of diabetes is 16.8. So clearly, things are not going the right direction in many of our countries. So how big is the problem when you look into the Dubai model? Well, I've shown you the problem of the prevalence of diabetes. When we look into the prevalence of pre-diabetes, which is mostly obese people, so 16.2% are the population of pre-diabetes. And when we look into obesity and overweight, which, as I mentioned before to you, it's about 60% or indeed over 60%, that's 840 persons. So if you look into pre-diabetics, that's 295,000 persons in Dubai, and obese is 840,000 persons. Probably there's an overlap of some of them. But nevertheless, if you just focus on the obese one, rather than they are pre-diabetic or not, that's 840,000 persons. So how can we prevent the obesity to become a problem with pre-diabetes or indeed with diabetes itself? We need desperately a national campaign, and we need an immediate structured program for the whole population, as well as long-term plan. So we need some plans now, and we need long-term plans. Now, after all, the government target for this year was to get a plan and to reduce the prevalence of the problem. And I think this is not something that could be done by a group of doctors. It needs definitely the interaction of multiple stakeholders. The Ministry of Health, the health authorities, the insurance firms, the Ministry of Education, of Trade, of Sports, the media, the medical societies, whether it's local or international, the pharmaceutical industry, and probably many more. But we need one plan that is immediate, that is evidence-based, that is culturally sensitive, that is acceptable to all ages. And because of the sheer number, it can never be a face-to-face clinic, because who will be able to address 840,000 persons? Let's even take 10% of them only, 84,000 persons. How can you all of a sudden accommodate 84,000 persons if only you would address 10% of the obese population in the Emirate of Dubai? And of course, we need long-term plans to prevent weight gain for adults and address childhood behavior to prevent obesity. The behavior change here is really quite important. So when I look into the classic studies which will be addressed by Professor Salah, clearly we see that lifestyle has been fantastic. Unfortunately, we don't have a program, so we end up providing our patients with metformin, which is indeed a drug they will take if they develop diabetes. I would like to share with you one important international study, which is the look ahead. I would like you to read carefully their objective. Their objective was, during 6 months, to decrease the weight by 7%, reduce the calorie intake, and increase physical activity. Why? To achieve and maintain. And I have highlighted and maintain in red, because achieving is not just the problem, but maintaining it. This was really the main issue. And because the study was stopped from being active after 1 year, you can see all parameters improving nicely after 1 year. But how can they maintain it when it is not maintained? So gradually, all the good parameters are lost. So unless you maintain the change, unless you maintain the weight loss, unless you maintain the reduction in the calorie intake, and unless you maintain the 150 minutes of physical activity, then all the good things will go back. However, those who maintained it and those who lost over 7% of their weight over the time, they were able to sustain the weight loss with a big difference, and this is 16 months, so this is 5 years. So 5 years of a group of patients maintaining 9% of weight loss because it's been maintained. So really what we need is something that our patients and our population can sustain. So my final slide or pre-final slide is, this really is a wake-up call. We need to address the epidemic of obesity, pre-diabetes, and diabetes in our region. The prevalence of this problem is very much related to obesity and physical activity. I cannot change age, but we can change obesity and physical activity. An urgent structured plan, rather than loads of referrals to be started on a GLP-1 receptor agonist, is what is required, and obviously with all the input of the various stakeholders. And finally, I'll leave you with photos of my beloved city, Alexandria. And I will look forward to your questions at the end of the session. Thank you all.
Thank you very much, Dr. Hassanein, for the excellent presentation. And we will move from here to the next topic about the management as the lead author of the guidelines by Dr. Salah Abustana. Dr. Salah is a professor of diabetes and endocrine. He's the head of Diabetes and Endocrine Center in University Hospital of Sharjah, head of Sharjah Diabetes Research, and the Deputy Chair, Clinical Science Department, University of Sharjah, UAE. So welcome, Dr. Salah.
Okay, thank you very much, Dr. Jamila, for the introduction, and thank you for the organizer for choosing such important health pandemic problem to be discussed tonight. I would like to thank the organizer and thank my dear colleague, Mohammed Hassanein, for setting the scene and highlighting how important and massive problem obesity is. So just let me take you through a few slides. And as I talking to internal medicine, it's really important to look at this patient who have probably most of these diseases. So if you look at the metabolic diseases like dyslipidemia, diabetes, cardiovascular disease, stroke, dyslipidemia, also thrombosis, gout, asthma, non-alcoholic fatty liver, gallstones. So if you look at those 4 or 5 boxes, probably our patient will visit almost every single clinic in the hospital, including the mechanical one, which is sleep apnea, chronic back pain, incontinence, arthrosis. So he'll see the orthopedic, he will see the sleep doctors, he will see the spine doctors, and he will see the urologists as well, and psychiatrists as well, because they might have depression and anxiety, and those are the mental complication. And if you put all those together, it's presented by one person who have all these complications, which make this person visit almost every single clinic in the hospital. The other day we're sitting with my student, we just try to calculate the number of the complications of obesity, and we reached 220. So it's quite an important disease to look at. So we have to choose, as Mohammed mentioned at the beginning, to prevent it and treat one disease, which obesity, or we left with the choice of tackling all those complications. This definition is quite important. We have used in our guidelines because it's not difficult to diagnose obesity or screen for it. So we have the body mass index. We have almost like 20 different measures to measure obesity, including using MRI. But all you have to remember is either the waist circumference or the body mass index. And you can see the classification there because those are important later on when you want to manage your patient. So the other important fact is, as all of you struggling to get the obesity covered by the insurance, we know that most of the societies, they have recognized obesity as a disease, and it's a big health issue, including the American Association of Clinical Endocrinologists, American Medical Association, and the US Food and Drug Administration, and the Obesity Society, the World Health Organization, European Medicine Agency, and European Association of Study of Diabetes, and the World Obesity Federation. So all these scientific societies, they have mentioned quite clearly that obesity is a chronic, prevalent in both developed and developing countries, as we have seen from Dr. Hassanein earlier. So let me just show you a few slides to show you why it's not easy to manage obesity and why it's complex. So in the olden days, we all say, well, it's energy expenditure and energy intake. So if you can keep the balance between the two, you are safe. It's not easy as that, because what we have discovered, it's a multifactorial disease, and that energy intake and energy expenditure and the imbalance between the two, there are lots of other co-founders for it. And we have multiple organs involved in the obesity causes and pathogenesis. So the adipose tissue, pancreas, gut, genetic, and medication all contribute to the complexity and the multifactorial causes of obesity. So we know the hedonic input might increase people's pleasure to have food, and the environment we are in, the inactive lifestyle, which mentioned very clearly earlier, and the smoking, the psychosocial factors, all playing a part together to contribute to the obesity. And that's why if you treat a multifactorial disease, the management is not easy. So going back to the same theory where the energy expenditure and energy intake, that these days sank away quite far. And I've done lots of work when it comes to the hypothalamus control of appetite and metabolism in my academic work. And all these circuits you can see in the brain, they being contributed to the control of the appetite and peripheral metabolism. So this slide shows you how complex it is. And you will agree with me, we need more work to be able to come up with the treatment which is effective to manage or treat those patients with obesity. This is a study, that's the action study. These are the data, the global data. And what basically the study is it's a questionnaire-based study, and we have published the UAE data. And I just showed this slide to show you that there are different questions being posed to patients with obesity and healthcare professionals who they are dealing with obesity. And I just showed a few of those gaps in obesity management. So when we ask patients with obesity, what's the issue? So for example, 82% consider weight loss to be completely their own responsibility. So if you see somebody with hypertension or diabetes, they will not say, well, it's our problem. No, they will say, but those who they are overweight or obese, they will say it's our problem because we are eating too much and we are not exercising. So they try to keep it for themselves and try to manage themselves. Only 55% of those who they have obesity received a formal diagnosis from their healthcare professional. Although I have told you, the computer does the diagnosis for you because you will see the body mass index for each patient come to your clinic. But we don't tell them, well, one of the problems you have, in fact, if it's not the main problem, is obesity. Of those receiving diagnosis, only 24% have follow-up appointment. And I can ask the audience now, for example, myself, when I see patients with diabetes, I get almost 100%, I give them follow-up appointment. Probably those who they don't treat obesity, what we have, the questionnaire study found, the action study, only 24% receive formal follow-up appointment. When it comes to the healthcare professional, most of us, they down the weight management discussion because of the time, because there is no time. And the healthcare professionals they set unrealistic weight loss targets. So it's 19%. So that's probably, if we want to achieve the target, we have to be realistic. Otherwise, it will be difficult to achieve those targets. So little believe in the efficacy of medical intervention when it comes to the obesity. This is what healthcare professional says. So those are the gaps, and I'll try to address those during my presentation and show what we have when it comes to the tools to treat obesity. The other important thing, I'm talking about the country we are living in right now. I'm practicing in UAE. I worked here for the last 10 years, 11 years. I've been on the National Committee of Diabetes, and UAE, one of the countries who they have very high spend when it comes to the healthcare. So that's 2015, and they spent 47.5 billion UAE dirhams on the healthcare, and 8.9 billion, that's 18.7% of total, it's been on the healthcare cost treating the complication of obesity. And if you go to the last box, which is the anti-obesity medication, it's only 64 million. So if you overlap those three boxes, when it comes to the obesity, it's what we are spending to treat obesity, it's quite low, it's a dot. So we have the responsibility as healthcare professional to stand up and say, well, we need to make sure that we save this country money, and we have to either prevent the obesity or spend more money to treat those who are obese to prevent complications. So let me show you the update when it comes to the management. There's always good news. So the good news is, if our patient or our population lose 5 to 10% of their total body weight, there is a benefit. And what's that benefit? There is a reduction in risk of type 2 diabetes. There is a reduction in cardiovascular risk factors, improvement in the liver profile, improvement in the blood pressure, and severity, improvement in the severity of obstructive sleep apnea, and in lifestyle and quality of life in general. And just rough calculation, if patient lose 1 kg, 16% relative risk reduction in diabetes, for example, which it's been shown earlier in the previous presentation. So although we are have lots of people with overweight and obesity, and if you look at the guidelines, we have more than 30 guidelines. So with my colleagues, we have sat down together and we said that let us have our local clinical practice recommendation to treat our patient. And tell you why we have our local, because we are different, and I'll show you a few examples there. I'm going to jump from one to another, but I'm going to cover the lifestyle, the pharmacotherapy, and the bariatric surgery, and the time allowed for me. So this is the algorithm, and this is the sequence. The screening is very important, and I think every single patient come to our clinic, either in the primary health care or in the internal medicine or hospital, all of them, they got weight and they have their height. So the BMI is calculated automatically. Then we can make the diagnosis much easier, and we have to set the goals and with the consideration, and we have to make sure we follow our patient up. So this is just to simplify the guidelines in one slide. So there are 3 items or 3 lines of treatment: behavioral therapy, pharmacotherapy, and surgery and devices. So when it comes to behavioral therapy, those would be BMI of 25 to 29.9 with no obesity associated comorbidity. Only they are obese. They don't have any of those complications I have shown you. They need to be counseled. They have to learn how to have healthy eating. They have to self-monitor themselves. They have to have physical exercise, stress management, sleep management. And that's done by a team. Unfortunately, it's not like a single-handed physician sitting in the clinic. The second line of the treatment is the pharmacotherapy. So those who they have BMI of more than 30 without any comorbidity, or those with 27 and above with 1 or more obesity-associated comorbidity, they are qualified for pharmacotherapy. And bariatric surgery, sleeve gastrectomy, gastric bypass, and pilopancreatic diversion for those who they have obesity, a BMI of 40 and above, or 35 and above with obesity-related comorbidity. So let me now just show you the gaps, okay, when it comes. I showed you the gaps when it comes to the time, when it comes to the medication, but I think we still, if you look at the range of weight loss, we still have a bit of a gap when it comes to the pharmacotherapy, although there are lots of medication coming through the buy for as anti-obesity treatments. So the health behavioral modification, pharmacotherapy, and you can see the percentage of the weight loss. Of course, the higher weight loss with the bariatric surgery, but we can't put every single patient on the table. So when it comes to the behavioral therapy, those are the major lifestyle intervention study. And what you can see, the reduction is just highlighting what Dr. Mohammed Hassanein said earlier, and you can see the risk reduction. It's quite massive. It's above 50%. So lifestyle is still the sort of fundamental line when it comes to the treatment of obesity. That's the DACing study, the Finnish diabetes prevention study, and the diabetes prevention program. And we have done quite a few studies here, and I'll show you the importance of those, because they, one of the times I was seeing patient when I first came here, and she said, I'm eating ergag, and I didn't understand what ergag is. So I asked the consultant beside me. He said, well, it's a bread. And I asked him how many carbohydrate in this, and he didn't know. And I asked my head of the lifestyle clinic at Rashid, and she said she didn't know. So he said, well, let us do a study and look at the glycemic index for the traditional types of bread in UAE, because we need to know what's the population are treating eating. And we've done that, and we come, and that's one of the paper we use in our guidelines. Again, we've done other study when it comes to the behavioral lifestyle intervention in patients with type 2 diabetes in United Arab. That's randomized controlled trial. Those are obese patients. We've done another one looking at the intervention of weight loss. That's a group-based program in this country. And all these are Emirati. Then we look at the vitamin D status in those who, and metabolic factors for those who they have obesity and diabetes. Also, we look at the supplement. If we supplement those who are obese and they have type 2 diabetes, will that make any difference? And again, we look at the all these, I'm showing you the randomized controlled trials. So they're quite strong trials. But what we have found is we are not different from the other world. We are the same. So we found patients lose weight, and they lose good amount of weight. But unfortunately, after that, they have regained most of the weight they have lost during the life intervention. However, if we look at the long-term study, the early intervention, the weight loss paid back later, 20 years later. So although they regain weight, and that's a problem, however, the benefit is there. So early intervention prevent diabetes and prevent lots of complication later on. When it comes to the pharmacotherapy, those are the medication available in UAE. We have this been withdrawn from the market last year, February, because of the increased incidence of the cancer, but this is what we have in this country right now. So I'll just grab one of the now hot topics, the GLB-1 receptor agonist as treatment of obesity. And we know the metabolic effect of GLB-1 receptor agonist. It's when it comes to the appetite, they increase satiety, fullness, and they decrease hunger, the prospective food consumption, and the energy intake. When it comes to the glucose regulation, it's increased the insulin secretion and decrease the glucagon secretion, and they got mild gastric effect, which decrease the gastric acid and gastric emptying decrease. And one of the GLB-1 receptor agonists is being licensed to treat obesity is liraglutide, which have homology of 90% of the native GLB-1 receptor agonist. And one trial, which is a scale trial, it's a massive trial, 5,700 participants were enrolled in this trial, and 28 countries, 400 trial sites, more than 50,000 data points available. And I will show you just the summary of the scale obesity and pre-diabetes and scale diabetes and scale maintenance and sleep apnea. So when it comes to the scale obesity and pre-diabetes, there's 8% reduction in body weight, 80% reduction in risk factor for type 2 diabetes over 3 years. Scale diabetes, 6% change in weight after 56 weeks, 1.3 change in HbA1c less. And the scale maintenance, 81% maintenance of more than 5% weight loss is 6.2 weight loss on liraglutide. And the same thing when it comes to the sleep apnea, you can see the improvement there. So those are the side effects, the 90% whatever effect, GI, and they are mild and not much when it comes to the other side effect. Bariatric surgery, this is our paper. We done like 450 cases in my previous center. And what we have found is for those who they have bariatric surgery, those mainly bypass, by the way, not sleeve. So we have few sleeve in the study, but you can see the reduction in weight, the reduction in the body mass index, and the reduction in the medication they were using. So that's the amount of medication pre-op, then 3 months, then 6 months. And not only that, if you look at the amount of money expenditure, it's been reduced. So pre-op is around 8,000 per year, and 3 months post-op is less than 380 and less than 300 after 6 months. So that's the cost-effective wise. And our study is not much different. We have lots of evidence. So we have 2 randomized controlled trial. We have 2 systemic reviews and meta-analysis. We have a cohort and 2 cohort study, and all of them showed that the bariatric surgery is more effective when it compared to the medical therapy. However, as I said, you can't bring every patient to the table to perform bariatric surgery. This is the long-term data. It's 20-year data, came from the SOS study. That's the Swedish study showing banding and gastric bypass. And what does it show? That patients, they still maintain their body weight, weight loss after 20 years, and that half the myocardial infarction incidence and prevalence in those patients. So there is growing consensus favor bariatric surgery, and that's why lots of society, they have that on their guidelines and they approve bariatric surgery. That's the American Diabetes Association, the first time announced in 2009. That's the American Heart Association 2011. Then the International Diabetes Federation 2011. And in fact, it was in this country, and I attended that conference, when they say bariatric surgery, it's one of the lines of treating obesity. This is the American Association of Clinical Endocrinologists. All of them, after the evidence I have shown you, they announced that bariatric surgery is one of the treatment. And now one slide, one of my last slides, is that the obesity and non-alcoholic fatty liver, lots of people asking about this. It's quite common, and it can be really with a prevalence of 15 to 30% in general population. However, in those with obesity, is 50 to 90%. So we have to make sure that we take that in consideration. So when it comes to steatosis, it's 65%. When it comes to those with grade 1 and 2, if patient with obesity grade 3, that goes up to 85%. And the stages of the non-alcoholic fatty liver is more familiar to you, internist more than myself, the fatty liver, then the NAS, then the cirrhosis. So it's quite, and the sequels, as been mentioned by Dr. Muhammad in the second slide or third slide, the first hit is that they increase glucose, the insulin, fatty liver, the free fatty acids, the adiponectin, and the chemokines, and decrease the adiponectin. All these with the adipose tissue contribute to the consequence of the. However, if you look at the 50 weeks of lifestyle intervention, you can see 5%, 7%, 10%, and the percentage of reduction of the progression of the non-alcoholic fatty liver. So weight loss is the major preventing factor and treating factors. And this is how the way we treat it. The first step for all patients is lifestyle modification, and that's the diet, how much they should have, and the exercise. The second step is the anti-obesity medication. And the third step is you can do bariatric surgery. So hopefully now we have something to treat obesity with the 4 or 5 different medications available in the market, and there are quite few. Lifestyle is the cornerstone, and it's the first. And the bariatric surgery, some procedure like banding and ballooning, especially in children. So with that, I would like to thank you very much for your attention. I'm quite happy to receive any questions. Thank you.
Thank you very much, Dr. Salah. We'll go now to the questions and answers from our attendees. There is one question from one of the attendees. Which surgical intervention you think is indicated, which is indicated, would increase endogenous GIP or GLP-1 resistance agonist in obese patients?
Okay, so I think they, shall I answer this, Dr. Jamila? Yeah, you want me to answer? Yeah, thank you. I think the question is like this. We see lots of patients with bariatric surgery. So whether the GLP-1 receptor agonist is effective in those patients or not. There are one study, it's very pilot study, which showed it's still effective. The reason why it's been asked, because we know in bariatric surgery, whether it's sleeve or bariatric or gastric bypass, the anatomy of the GI is changed. So when it comes to either the hypothalamus, the GI hypothalamus feedback, or to the delaying gastric emptying, it might be not effective. So in my practice, if I see somebody, okay, who got bariatric surgery and they start regaining weight, I do restart them on GLBR receptor agonist. And most of those patients, they have diabetes as well. So they have the double benefit.
There's a related question here. How is the tolerance of GLP-1 agonist?
That's a very good question. So for those patients who they are compliant, okay, when it comes to the amount of the meal they are taking, so the tolerance is very good. For those who, bariatric patients, because they start eating a good amount, so even the batch of the stomach left, or the 20% or 15% of the stomach left after sleeve gastrectomy, that got dilated. So if that's the case, patients sometimes they don't tolerate it. But the patient, at least as I said, the one I have restarted them on GLBR receptor agonist, what I asked them to take it away from the big meal. So, and the other thing is to make sure that they don't stop the medication in the first 3 weeks if they have nausea or vomiting. That will get better. It's same as those who they didn't have bariatric surgery before.
Okay, we have one of the candidates who is concerned about the weight loss diets here. Does the ketogenic diet increase the cardiovascular risk?
May I take that question?
Yes, please, doctor.
On the short term, no, but on the long term, yes. However, I am not sure that ketogenic diet is a long-term type of diet. Most people who take the ketogenic diet, they get bored of it and get tired of sustaining it beyond few months' time. But in theory, obviously, it's a diet that is rich in fat and rich in protein. So although it reduces the weight, but on long term, it can have a negative impact on lipids profile and can be harmful from a cardiovascular point of view. So on one hand, you have the benefits of weight reduction, but on the other hand, you have the disadvantage of the change in lipids profile.
Okay, thank you very much, doctor. There's another question. What is the longest duration of type 2 diabetes patients becoming free of taking either insulin or oral hypoglycemic agents after having bariatric surgery?
Okay, probably both of us need to tackle this question. Very important, the time, how long they will be free from taking the medication is how early you catch them. So for example, if you have somebody who are obese for 5-10 years, the beta cell mass or the beta cell function, and thus we do the C-peptide before we do the bariatric surgery, is one of the blood tests we do. We want to know the beta cell reserve. So it's all depend upon the beta cell reserve. So the earlier you intervene, the the remission of diabetes will be. That's very, very important. Sometimes you do bariatric surgery, although patient will benefit from the other complication, but when it comes to the diabetes and anti-diabetic medication, they don't benefit a lot because they reach to absolute insulin deficiency. So those will not benefit from that stopping the medication, or they have remission when it comes to the diabetes. So the earlier you do it, the better. It does not necessarily bariatric surgery, even lifestyle. The important thing is how quick we stop the medication. We done, as I said, like 450 cases serious, and we stopped them in the first week. On the second day, we stopped half of the medication. And in the rest of the week, we stopped almost every single diabetic medication. And I showed you not only the diabetic medication, I showed you the amount of money. It's less than 300 per year, dirhams per year, in comparison to 8,500.
If I were to add to what Salah mentioned, in some of the studies from Sweden and from the USA, looking into long-term remission, by long-term, usually is 3 years. Very rarely it is longer than that. Some of the studies from the USA have been to 5 years. There are about perhaps 30% who up to 5 years are with an HbA1c of less than 6 or less than 6.5, which is obviously considered not diabetes, but perhaps pre-diabetes or neither. So we have studies for 3 to 5 years, and perhaps in small proportion it could be even longer, but that's dependent on the type of surgery. And as Salah mentioned, the crucial point is how early in the disease process they went for surgery.
Thank you, Doctor. Here is another question. Is it justifiable or acceptable for the physician to persist in medical therapy in an obese patient with type 2 diabetes who has or still or persistently had a high HbA1c?
The answer,
should we maybe should we go for a bariatric or surgical intervention in that case? Could be that is what they mean here by the question.
Yeah, well, yeah, go ahead, Mohammed, go ahead.
Well, bariatric surgery is for a small select group. If you think of the prevalence of diabetes in UAE, that's about 15 to 16% or even higher. We are talking about 1 million person living in UAE with type 2 diabetes. Now, can we afford to do bariatrics? And the vast majority of them will be overweight or obese. Can we really afford to do bariatric surgery for all of them? The answer is obviously and possibly no. And plus, the surgery is not free of complications. As an endocrine center, we on a weekly basis see post-bariatric surgery hypoglycemia, because bariatric surgery is very good for people who are bulk eaters. But sweet lovers, they can still overindulge, and they end up with, they haven't changed their behavior. They went to a surgeon who convinced them that I will fix your problem. But they can still have the chocolate and the ice cream and the sweets and the sweet drinks in a small stomach. And with the bypass surgery, they end up with dumping syndrome. And we, on a weekly basis, we get at least one referral of post-bariatric hypoglycemia, because these people have not been exposed to behavior change in advance. So certainly bariatric surgery is not for everyone. Some people fail surgery. It's a good option for some patients, but it needs to be well selected after going for all the steps to make sure that the outcome will be successful.
Yeah, one point to add here, Dr. Jamila, if you allow me. Adding to what Dr. Mohammed have said, is whether we continue, for example, those who they being mentioned, whether they are resistant to a Glbr receptor agonist or not, for those who they are obese and they have diabetes and they have high HbA1c. And the answer to me is 100% yes. Why? Because as Mohammed said, we will not be able to cover every single patient, but on top of that, the anti-obesity treatment, the incretins in general, they have other benefits. which is the cardiovascular benefit, and again, the anti-diabetic effect benefit. So to continue the GLB-1 receptor agonist for those, yes, the answer is yes.
Okay. There is one last question here we will take because of the time. Is there any role for vitamin E or pioglitazone or metformin in NASH management? I don't know if this is related to
NASH management, I mean, I don't know whether Salah would like to step in, but NASH management, the cornerstone for it is weight loss. Obviously, some of the drugs that work on the central adiposity and the insulin resistance, such as pioglitazone and metformin, are helpful. We do not have a single drug specific for NASH, but it's all kind of like a byproducts that can help. But the bottom line is they need to improve their weight. I'm not sure of the effect of vitamin E. Salah, are you familiar with effects of vitamin E on NASH?
No, I totally agree with you, Mohammed. In fact, the data we have is that 10% weight loss slow down or the progression 70 to 80%. So probably no single medication will achieve that.
So I think we have come to a conclusion of our scientific topics today. Thank you very much, Dr. Hassanein and Dr. Salah, for the excellent topic and the discussion.
Thank you very much.
Thank you.
We appreciate it. It was very informative. Thank you very much for that.
Thank you very much. Thank you.
Thank you. Thank you.
And I believe we would go now for the last part of our session today, which is the industrial symposium here about the latest update in the management of heart failure with SGLT2. So thank you very much. Please, Ms. Serena.
Thank you very much, Dr. Jamila.
أهلا وسهلا. تفضلي.
So thank you very much and good evening, doctors. At first, on behalf of Boehringer Ingelheim, I would like to extend our sincere appreciation and thank the scientific committee for the Internal Medicine Society for granting us this opportunity to share the latest updates when it comes to the management of heart failure, in particular the reduced ejection fraction with SGLT2 inhibitors. Allow me please to introduce myself. My name is Serena Othman. I'm the Senior Medical Science Liaison for Metabolism in Boehringer Ingelheim. And before we go in depth into the latest data on SGLT2 inhibitors when it comes to the management of heart failure, I would like to take you back a little bit in time to where this data originated from, or what was the background data behind those heart failure trials that are now taking place on SGLT2 inhibitors. It was mainly the cardiovascular outcome trials that were originally mandated by the FDA on those drugs to assess their safety in patients who had diabetes and atherosclerotic cardiovascular disease. So if we look at the EMPEROR trials that are mainly studying patients with heart failure, reduced ejection fraction or preserved ejection fraction, it all goes back to the 35% relative risk reduction that has been achieved in the EMPA-REG outcome trial, basically in patients with type 2 diabetes and atherosclerotic cardiovascular disease. Now, briefly, who were the patients that were studied in the EMPEROR reduced trial? Those were mainly heart failure patients with reduced ejection fraction, left ventricular ejection fraction below 40%. And elevated NT-proBNP, mainly exceeding the predefined levels that mainly vary whether this patient had atrial fibrillation or not. Most importantly, that the patients that were studied, we were not assessing whether those patients did have diabetes or not. So the EMPEROR reduced did include patients with and without type 2 diabetes, and they were ranging in the NYHA class between 2 to 4. Now, before I start talking about this slide, I would like first to highlight that this is not intended at any time to be a comparison between the EMPEROR-reduced and the DAPA heart failure that was conducted on dapagliflozin. The main objective of presenting this slide is to present the broad spectrum of heart failure patient in the inclusion and exclusion criteria of both trials, meaning how the SGLT2 inhibitors are now embarking a new journey in the heart failure management, aside of the diabetes and glucose control that it had before. So if we look into the inclusion trials of inclusion criteria of both trial, we can tell from the levels of NT-proBNP and the EGFR cutoff point that the patients who were studied in the EMPEROR-reduced were sicker compared to those studied in the DAPA heart failure. And the EMPEROR-reduced did include patients with EGFR up to 20 milliliter per minute. Now, again, we are not comparing those two trials. We are just presenting the broad spectrum of patients that were studied in both heart failure trials. Again, if we look at the mean left ventricular ejection fraction or the NT-proBNP at baseline, the history of patients who had or who were hospitalized for heart failure, the average EGFR at baseline, again, we can tell that the patients that were studied were sicker. Even if we look into the medications that were on, yani in the EMPEROR-reduced, 20% of those patients were on ARNI, sacubitril valsartan, compared to 10% in the DAPA heart failure. So the patients that will be we will be mainly focusing on tonight are very sick heart failure patients studied with empagliflozin compared to placebo on top of standard of care. So in a nutshell, 3,730 patients were studied. Those patients were on top of standard of care, meaning that those patients were on ACE or ARBs, beta blockers, MRAs, ARNIs, or diuretics. EMPEROR-reduced was an international large-scale study. The patients were randomized into two arms, EMPA-10 versus placebo. This was an event-driven trial. So once 841 adjudicated primary endpoints endpoint events were achieved, the study had to stop. The mean follow-up for this trial was 16 months. So what were the endpoints? What were we studying in the EMPEROR-reduced? Starting with the primary endpoint, it was a composite of time to first event for either cardiovascular death or hospitalization for heart failure. Key secondary endpoints included occurrence of adjudicated hospitalization for heart failure, whether first and recurrent, and the change in EGFR from baseline. In addition, we had exploratory endpoints. We had renal endpoints, change from baseline in KCCQ questionnaire at week 52, mainly assessing the improvement or the change in the lifestyle in heart failure patient, in addition to time adjudicated cardiovascular death. Moving directly into the primary endpoint, which was a composite of the first event of either adjudicated event of either cardiovascular death or hospitalization for heart failure, a 25% relative risk reduction was achieved, absolute risk reduction 5.2 and 19 number needed to treat. And most importantly, that we did achieve an early separation of the two curves in favor of empagliflozin 10 on top of standard of care. Now, if you look in depth into the subgroup analysis of the patients that were studied, so if you look at the consistency of the results, whether those patients did have diabetes or not, we can say that even if this patient is diabetic or non-diabetic, the benefits of empagliflozin did still extend. So the primary endpoint was still consistent, statistically significant, clinically meaningful, whether this patient did have diabetes or not. In addition, if we look at the other parameters, age, gender, race, BMI at baseline, and the baseline at GFR or the renal function, we can tell that the benefits of empagliflozin were still consistent regardless of the baseline characteristics or the subgroup analysis. Even if we go in depth into whether those patients were on MRAs or not, or whether these patients were on ARNIs or not, the benefits of empagliflozin did still extend. Moving to the key secondary endpoints, and here we are looking into the adjudicated hospitalization for heart failure, whether those hospitalizations were first and recurrent, and a 30% relative risk reduction was achieved, statistically significant, clinically meaningful, and again, most importantly, an early separation from the placebo curve was witnessed. Moving to the renal benefit, and here we are looking into the change in eGFR slope from baseline. Again, if you recall, the patients that were enrolled were on top of standard of care in the in both the placebo and the EMPA-10. In reference to the mode of action of SGLT2 inhibitors, we do witness an early dip in the eGFR. This early dip is acute. It is mainly witnessed in the first, second to 4 weeks, and mainly attributed to the reduction in the intraglomerular pressure and glomerular filtration rate. However, if we look into the long-term effect or long-term benefit, we can tell that we did achieve or witness a preservance in the renal function in the empagliflozin arm compared to placebo, with a 3.3 ml in favor of empagliflozin when compared to placebo. Now, if we look into the exploratory endpoints, and here we are looking into the renal endpoints, the change from baseline in the KCCQ questionnaire at week 52, and here we are again mainly looking at the improvement in the lifestyle and the quality of life of the heart failure patient, in addition to time to adjudicated cardiovascular death. Starting with the individual components of the primary endpoint, which is first hospitalization for heart failure and cardiovascular death. When it comes to the first hospitalization for heart failure, a 31% relative risk reduction has been achieved and was statistically significant. And when we look at the cardiovascular death, we did achieve an 8% relative risk reduction in favor for empagliflozin, yet this reduction did not reach its statistical significance. When we look into the composite renal endpoint, which is the end-stage kidney disease or sustained profound decrease in eGFR, again, empagliflozin did achieve a relative risk reduction of 50%, an absolute risk reduction of 1.5%. And this goes back as well to sustain and to maintain what have been achieved in the previous trials of empagliflozin, especially in the EMPA-REG outcome trial, sustaining the results, and meaning that the results have been, the renal benefits that have been achieved in the EMPA-REG outcome trial are still extending into the EMPEROR-reduced heart failure trial. When we look into the KCCQ questionnaire at week 52, again, empagliflozin did achieve a benefit of 1.7 unit when compared to placebo on top of standard of care. Now, moving into the changes in vital signs and the safety profile of empagliflozin when compared to placebo, we did achieve with empagliflozin a slight reduction in the glycated hemoglobin, a slight increase in the hematocrit, slight reduction in the NT-proBNP, body weight, and systolic blood pressure. And when we look in depth into the safety profile of empagliflozin, no difference between the placebo arm and empagliflozin, mainly in the rates of hypotension, hypovolemia, hypoglycemia, and no cases of ketoacidosis have been reported. And moving into the serious adverse events or the general adverse events that have been achieved in the EMPA and the placebo arms. So when it comes to the patients with any adverse events, we can tell that the percentages are comparable. We did witness an increase in the serious adverse events in the placebo arm compared to empagliflozin. The main adverse event that was slightly higher in the empagliflozin arm were the genital tract infections, and the majority of those cases that have been reported were mild to moderate cases. So putting the results in context, and here we are looking into the electrolyte imbalance that is mainly attributed or seen in the therapists with or that include a diuretic effect. We did not witness any of those imbalances in the SGLT2 inhibitors in general. So no hyperkalemia, no hypokalemia, or other electrolytes imbalance. And even if we look when it comes to the hands-on experience and the dosing and titration, when it comes to the use of SGLT2 inhibitors compared to the other conventional heart failure therapies, we can tell that there is no need for any dosing up titration with a very good safety profile. And this goes well by the latest consensus that has been recently released by Professor McMurray and Milton Packard that are recommending the use of SGLT2 inhibitors in general early on based on their positive results in their respective trials, in addition to their favorable safety profile and ease of use. Again, here we are looking into the results. No intention at any time to compare those different trials together, but to establish SGLT2 inhibitors as part of the foundational therapy for the modern heart failure management. Moving into a meta-analysis that has been released last year by Professor Faiz Zannad, mainly looking in depth into the both heart failure trials, EMPEROR-Reduced and DAPA heart failure, to assess and further understand the effects of SGLT2 inhibitors on the exploratory endpoints in patients with heart failure and reduced ejection fraction, and have a conclusion of the totality of evidence of both drugs. And here, if we look at the primary endpoint, which is mainly the first hospitalization for heart failure or cardiovascular death, we can tell that the totality of evidence is in favor for the SGLT2 inhibitors when compared to placebo. And even when we look in depth into the cardiovascular death, despite that empagliflozin in the EMPEROR-Reduced did not meet the primary endpoint, if we look in total at the totality of evidence, it is in favor of the SGLT2 inhibitors when compared to placebo. Here we are always emphasizing on the interrelated relationship between heart failure and kidney injuries, and unfortunately no treatment options have been identified that would provide sufficient kidney protection in patients with heart failure. Now, there is always this question, why are SGLT2 inhibitors, why do they have those beneficial effects on heart failure? There is like a collective of hypotheses that would add up and contribute to the benefits of this class in improving and reducing cardiovascular death and hospitalization for heart failure. It mainly goes back to the reduction in interstitial edema, reduced preload, afterload, and reduction in LV wall stress, improved kidney function, and the cardiorenal physiology, and so. So to conclude, when it comes to the EMPEROR-Reduced, empagliflozin did meet the primary endpoint to time to first cardiovascular death or hospitalization for heart failure by a 25% relative risk reduction. When it comes to first or recurrent hospitalization for heart failure, a relative risk reduction of 30% has been achieved, 1.73 ml per minute improvement in the eGFR of slope per year. When it comes to the exploratory endpoint, a 50% relative risk reduction has been achieved in the composite renal endpoint. 8% reduction have been achieved in cardiovascular death. It did not meet the statistical significance, and an improvement of 1.7 unit in the KCCQ questionnaire. And most importantly, the safety profile in all participants was similar to the well-established safety profile of empagliflozin that has been previously witnessed in the other trials. So this does put SGLT2 inhibitors as a crucial part of the foundational therapy in heart failure. And by this, I end my slides. Thank you very much.
Thank you very much, Serena, for your
Thank you, Dr. Jamila.
presentation. And in conclusion here, I would like to thank our presenters, Dr. Mohammed Hassanein, Dr. Salah Abu Snana, for the excellent topics today that were discussed, the information that we have gained. I hope that the updates in this webinar has added to our audience here. And thank you, Serena, for your presentation as well. And I think we're coming to a conclusion today. So thank you very much for the audience, for your attendance. And we would hope also to have you with us in our upcoming webinars, inshallah. Thank you very much, everybody. So we'll come to a conclusion.